talk about. If you could point them in that direction, that would be great. Any questions or comments that anybody has, please pop them in the chat and we'll address them as we go through or at the end. And just to let everybody know that today is National Pineapple Day. Who knew? So why not take the opportunity to enjoy this tropical fruit in whichever manner you choose to. So let us crack on. So I'll give you an update first of all in terms of the highlights from the tactical meeting. So this is the meeting that happens every Friday morning, trust-wide, chaired by Claire Smith, our Chief Operations Officer. And just to say, I'm Suzanne Abrams, the General Manager from the Children's Hospital, just in case anyone doesn't know me. So on Friday, we were advised that there were 90 patients with COVID that were in the bed base and 1 in critical care, and it is expected that that number will increase slightly over the next 2 weeks, but hopefully won't have to engage any of our surge plans, but the plans are in place if we should do. Across the country, there are 6 new outbreaks, and there are outbreaks within the hospital, and L18 is temporarily changed to a COVID cohort. Previously, most patients presented with a need for oxygen, but this time it seems that they presented mainly with other things requiring specialty input, so with surgery or a cardiology complaint, and this is being picked up. It's predominantly in the 65 plus age group, and we remain with 1 red ward over at St James's. It's the first time that we've experienced a bit of an increase as we try to live with COVID. So we need to realise that and kind of understand that as we move forward. What we learn now will feed into our winter plan, so it's really important that any lessons learned or shared learning are shared and that we know what we're doing. So we've got a bit of a heads up going into the winter, and it was noted that the children's COVID plan is very robust and well established, so that was good that we had recognition for that. In terms of an IPC point of view, the inpatient testing for COVID guidance has changed. There was a steer towards LFTs, but this is now changed back to PCRs because it's easier for reporting purposes rather than ward staff having to report the LFT results. There'll be changes to PPE from the 4th of July, so masks will stay, but routine use of aprons, gloves and eye protection will be removed. In terms of the other outbreak that we would discuss, I have an eye on really, is MPX, which was monkeypox, but now known as MPX. There are 12 cases in Yorkshire and Humber, with 900 cases across the UK, with no mortality reported. High risk is noted for pregnant women, and we need to be aware of various ways in which it may present. So to protect yourself from MPX, maintain PPE when assessing patients, apron, face, mask and gloves should you think it necessary. If you MPX is likely, ask infectious disease colleagues for advice and upgrade your PPE to FFP3, mask and eye protection. Again, the excellent work that we do here in children in terms of IPC assurance was noted as well. And then polio was the other thing. So the vaccine, so this news is not entirely unexpected, and the vaccine-related transmission is not unheard of and used to be more common in the UK when we gave the vaccine on a sugar cube. Now we use the injectable non-live vaccine, but other countries still use the live vaccine, and following this, the virus can be excreted from the body, apparently. Hence, it has been isolated in samples from sewers. So patients present with floppiness, and if a patient presents in this way, we need to send oral and rectal swabs. So that's it in terms of infectious diseases. And then there were updates from the across the organisation in terms of the cancer transformation programme and the use of artificial intelligence and innovation to achieve earlier diagnosis, which is fantastic, wonderful development. Hello. I shall proceed. If somebody needs to say something, if you just pop your hand up, and if someone could let me know, that would be wonderful. Oral lesion photography for GPs and dentists, which allows clinicians to triage and potentially immediately discharge patients referred on a potential oral cancer 2-week wait pathway has been implemented in trials. The colon capsule endoscopy to reduce the need for colonoscopy and CT colonoscopy, again, is being trialled and rolled out within the UK. All wonderful things like that are happening, again, to improve the pathway, reduce the pathway, improve the experience for our patients. In terms of health inequalities, the overall goal of all of the work is to diagnose the cancer as early as possible in order to maximise outcomes, and this also requires that we address the health inequalities within cancer pathways. We know in children that we've got several work streams set up in terms of addressing health inequalities, and we're doing that mainly via the Children's Hospital Alliance, which is really developing and going great guns. There's a lot of work that's ongoing with that, such as the using an artificial intelligence tool which will identify the patients who are likely not to be brought, and then putting in intervention to support those families to be able to bring the children to their appointments, be that with travel expenses or whatever else it may be. So that was it in terms of the majority of the issues that were discussed at Tactical. So we go on now to talk about what was discussed at Bronze and also the operational pressures for last week and the week ahead. So Laura, I believe you're picking both these things up.
I am. Thanks, Suzanne. Good morning, everybody. I'm Laura Whelan. I'm the Deputy Head of Nursing for the Children's Hospital, in case you haven't met me before. So in terms of Bronze, which is our weekly meeting of our Deputy Tri and matron group, we were looking at the proposals that the Trust were making in terms of changes to PPE. We were asked to feed in a response to what they were proposing, and Suzanne's just described there that that's all gone through and been ratified, and that the changes will come into effect from the 4th of July. And just to reiterate, so masks will stay, and it will be aprons, gloves and protective eyewear that will be leaving our PPE regime, which I think will feel strange to a lot of us. So obviously you still need to wear your gloves and your protective eyewear and your aprons when it is appropriate to do so, but as a routine they will be going. And we're also still working through how we will begin to reduce restrictions in terms of our play areas and our staff break areas. So we're still working through that, and hopefully we'll have a position by next week. And then in terms of our operational pressures last week, we were really pressured for beds. I'm sure you all know that, and we had a really low discharge rate, so a lot of long-term patients within our bed base at the moment. So in terms of how many available beds we have to generate some flow is really reduced at the moment. So the good news though, that we've opened a 7th operating room, and we have managed through the incentive shift for nurses to support staffing the step down ward areas for the patients that go through that theatre, which is really fantastic. So just to give you an example, between the 20th and 30th of June, we were managed to give treatment to 33 children who have waited more than 2 years to receive care, and that was obviously supported using the 7th OR and the Imagine incentive that we've got on at the moment. So that's really amazing for 10 days, and it's certainly ramping up this week and next week. So I think when we do another 10-day snapshot, it will be much greater than 33, which is fantastic. So thinking about the week ahead, we're really pressured through Peds Quick Care this morning, as we went into the bed meeting this morning, and also neonates. So we have got surge beds open, and we're just working to respond and try relieve some capacity in all of those areas. Our focus really is on discharge. I know it's really tricky at the moment, but trying to focus on getting as many patients out as quickly as we can, as soon as they're well enough to go home. We're also looking at repats. So if you've got any patients that are awaiting a repat bed anywhere, please can you just escalate them early through the normal channels, so that we can begin to start having those conversations with our colleagues, either regionally or nationally, to try and secure beds for those children, again, to give us a little bit more capacity. So yeah, that's it really. Thank you, Suzanne.
Thanks, Laura. So I'm going to update now in terms of the financial position, and this is a really important kind of briefing that I'm going to give you now, following a briefing that was given from Simon Worthington, who's our Director of Finance. regarding the trust's financial position and what that means for us as a children's hospital. So we, as a trust, going into the year 22-23, we all had to develop waste reduction plans that would save £70 million. What has transpired in the first couple of months of this financial year is that we're going to have an additional £68 million problem on top of that 70 million. And that's made up of the fact that we thought we were receiving many millions from elective recovery funding, which means we have to achieve a certain level of activity to receive that funding. It looks in the first couple of months that we're not hitting that level of activity, which means we won't receive that funding, and therefore that gives us a significant problem. So that's about £40 million worth of a problem. Inflation's a lot higher than predicted. Utilities, so we're just coming to the end of our hedging agreement as a trust with the electricity and gas companies, whereby we can agree a price and pay for a lot of bulk buy energy up front. That's just ended at the wrong time, so we're having now to pay a premium, and that's hit us. And because of that, that means that we are having to put in a mitigation plan to try and resolve this, because if we go as we're at the rate at which we're going and spending, then that's going to be unsustainable for the trust. So the executives have put together a mitigation plan to hopefully take action for all the CSUs and try and mitigate against this deficit that we're facing. So as I say, there's that £68 million problem that can be offset by certain things that aren't included in the mitigation plan. So instead of getting 40 million, we think we'll get 14. That's 14 million from the ERF money. There's some, as Simon went into describe, back of the sofa money that we can put in there that equates to about 6 million. There's various different savings from transformational problems. So the upshot is it leaves a gap at the end of the day of 34 million, and that's what the mitigation plan has to resolve. So the mitigation will be done in the following ways. The elective recovery funding that we thought we would receive, and that each CSU was said you have X amount, is going to be reduced based on the activity. For us as a children's hospital, we're actually achieving our activity targets. So the amount by which our elective recovery funding will reduce is not that great. It's by about £200,000, and we've received about 2.2 million. So it's not a great deal for us, and won't be too much of a concern for us as a children's hospital. The second work stream of the mitigation plan is the variable pay and vacancies. So this is assuming that we will make a saving because the high cost agency and bank rates that were used for the right reasons to respond to the pandemic will not be used anymore. Now that's a separate thing to the Imagine project, which we have within the Children's Hospital, because the Imagine project is funded through the ERF money that I've just explained we've received the vast amount of. This is for the surge rates that we were using to keep to cover high levels of sickness, to keep the wards going, and absolutely it was the right thing to do. And if we get in that position again, that will have to be looked at. But the assumption is that those very high surge rates that were being used and had to be used to keep things safe will no longer need to be used, and we will make a saving because of that. So we've got about a £750,000 target against us as a children's hospital to do that. Then there's the discretionary non-pay work stream. So this is looking at less essential areas such as station furniture, fixtures and fittings, not medical and non-pay. So all requisitions that come through that have a budget code that link to one of those discretionary pay categories that I just described will be put into a holding pattern. The procurement team will review and either accept, reject or ask for further information. And then as a try team, we will have to review those applications and again do the same to say it's either accepted or rejected. So if you need a desk for an office now, it won't be as simple as placing an order for that. We need to look at all the other things that we need to look if we can repurpose from somewhere else, a different CSU, a different site perhaps, just to reduce that level of waste. So that will be something that will be changed moving forward. So in terms of moving forward for us as a children's hospital, that all of that means that we will get a change to our control total, our budget, if you like, by about £800,000. So it will be an additional £800,000 we will be required to save. I think a lot of that will be done through the not using the enhanced super surge rates that we were using. And also there's that discretionary pay that will contribute towards that, but we'll do it. We'll do it in the Leeds way. We'll do it together. We've always worked in that way, so we just need to continue doing what we're doing. But people need to know that there'll be a lot more scrutiny on spend. And again, a huge plea for any ideas people have about reducing waste. Please do voice them and let Liz Smith or Kirsty Bray know. That's loads of information. If anyone's any questions or anything, pop them in the chat or just drop me an email and I can reply. That is literally hot off the press. We got those figures through at 5:30 on Friday. And then in terms of waste reduction, it's just to give you another nice example of what's happening in other areas. So in the oncology day unit, they've made savings by switching to a cheaper brand of adhesive remover. So having identified high cost and high expense on the adhesive remover, they've looked at how they could save money without compromising on care. Appeal is the product most widely used across the CSU and the most expensive. It's a superior product that allows immediate application of a new dressing after use with no compromise to how the new dressing adheres. However, where no new dressing will be applied immediately, there are cheaper and equally effective products that can be used. So the oncology day unit started using Lifties spray, which is a 50ml multi-patient use spray. And they also started to be more mindful of how much adhesive remover is required to achieve the necessary results. And as a result, the reduced wastage and excessive use of all adhesive remover products with annual savings of approximately £2,500. And that doesn't compromise patient care or comfort in the slightest. So it's just another example. If that could be used in your area, please do ask Liz Smith about it, but just to try and kind of initiate a bit of thought really and some ideas on that. If there are any other things that people think that they can use, please do have a think about that. And then, oh God, then it's me again. It's a bit like the Suzanne show today, so apologies for that. But in terms of lessons learned, I just wanted to feedback something that had happened through our health and wellbeing group. So we have our health and wellbeing group that I chair that happens every month. And we invite leaders to come along and having reviewed the staff survey results, having a conversation with teams to identify what the top 3 things that we could help with that would improve people's working life experience, and seeing how we take it from there. And we had a really good session the week before last with a couple of line managers who came along, and there was some stuff we could really help with and move forward, but there were some things that we could have helped with a lot sooner. So the lesson learned is if there is something that you think would be a good idea for your team and you need just a little bit of help or advice or anything to be able to get that to happen, then please speak up. Don't wait for a formal meeting or something like that until that time. So one of the examples was a timeout was suggested for the team, but there wasn't the budget to do that. But we have various different avenues we can look at that, including organisational development funding or possible charity funding, which I've helped support an application to the charity for that particular one. So especially as things are getting slightly more normal in the workplace, we can look at doing things like that. So please do speak up and don't wait for a formal meeting necessarily. If there are little things like that we can help with, please do speak up. And in terms of sharing success, we had Caroline Steele come along to the Tri meeting last week, and I know that the first Q clinic was launched last week, which was a tremendous success, and Caroline's going to come along to a future Muddle to give us far more insight and an update on how that went and plans for future clinics, so we'll look forward to that. And then I just have one more thing for any other business in terms of just to flag up that Grand Round tomorrow has got a work topic on there, freedom to speak up, and Joe Cohen is coming to do So we can give people a bit of a highlight and signpost towards that. Oh, so that's that. Are there any questions in the chat as I've been prattling on?
Hi, Suzanne. There is just one question from Kathleen Smith, and it might be one for Laura, just around PPE and whether or not we are maintaining PPE in non-clinical areas. Don't know whether you've got any more detail on that, Laura.
Oh, I have to go check the detail, actually. I don't think that they've done non-clinical areas at the moment. My understanding was that masks were remaining in non-clinical areas, but I will go back and double check the guidance. I think the focus has been on the clinical, but I will double check the non-clinical, and I'll put something into the chat.
Lovely, that's great.
And that was it for questions.
Lovely. Okay then, well, thank you everybody. Thank you for bearing with me. I hope some of that information was useful, and if anybody does have any more questions or queries, particularly with regards to the finance, please do just dash a line manager or drop me a line and I'll clear anything up. We're learning as we go with this one, so we'll have a bit more clarity next week, hopefully. Thank you for joining us. Have a lovely week. Thank you, everybody.
Thanks, Suzanne.
Thanks, Sam. Bye all.
Everyone.